Oh, well, with all of you guys there already, we probably should get started. Let me introduce the lovely Fatima and Annabelle, who will be leading today's talk on potassium derangement, specifically looking at hyperkalemia and hypokalemia.
Right, so thanks Akash for that introduction. So today's webinar, as part of the series, is about potassium derangement. I'll go through them each in turn, and hopefully by the end you'll be quite happy with trying to manage this when you're doing your F1 job, or indeed any ward-based job. So just before we start, so last week we trialed Kahoot questions, which proved to be popular in the feedback. So we're going to use that again. As we mentioned last week, there's a little bit of a delay between us doing this via Zoom and you guys hearing it on Facebook. So mostly we're going to be using this to test your knowledge before we kind of explain what the answers are. So throughout the talk, I'll have slides where the next question will be enabled on Kahoot. For you to join, you need to go on kahoot.it, and we'll have a link of that in the Facebook chat, or use the Kahoot app, and you need to enter this code. It's on the screen now, 8791840, and you should see a screen like this. So we've got a couple of people joined already. If more of you join in, that will be great. So I'll let you guys get on with that as I crack on, and then when the first question comes up, I'll show it to you as well. So just a quick shout out to our sponsors, the MDU, who have been supporting us throughout this webinar series, and we will also have a link as well in the chat for you to join. You obviously need indemnity cover as an F1, and this is one of the biggest organizations that offers that, along with a lot of other perks. Another housekeeping thing. So on the Mind the Bleep website, we have a really good course called Sweet and Salty. It's usually $9.99, but we are offering a giveaway. It's on diabetic and electrolyte emergencies, online course, really useful. So it's free to join the giveaway. So if you just go in on mindthebleep.com/giveaway and enter, you'll be in with a chance. Right, so let's go on to question 1. So I'll just start that. So this is going to be on hyperkalemia and how you define it. So I'll leave you a bit of time to answer that. Obviously, there's maybe slight differences in the exact level, but broadly speaking, what is hypokalemia, above what potassium level? So you can answer that separately as we crack on. So hypokalemia, we're going to go through the definition and the classification. Why is it important that you know about this? We'll go through the causes and what kind of symptoms you might expect with your patients. And then we'll go on to what you actively need to do if you've got a patient with hypokalemia, the investigations you need to do, and importantly, the management. So classification, a potassium level that you're measuring with blood is an extracellular potassium level, obviously, and anything more than or equal to 5.5 millimoles per liter, or depending on where you are, milliequivalents per liter, is considered a hypokalemia. It's subdivided again according to severity. So mild will be anything up to 5.9, moderate is from 6 to 6.4, and then severe is anything above or equal to 6.5. So why is it important to know about hypokalemia? It's one of the most common electrolyte disorders that I've personally encountered and my colleagues have when we're covering the wards. I probably can't think of a shift where I didn't have to manage it. So it's important for you to know how to manage that. The other second reason, the most important one, is that it can be life-threatening, particularly with regards to how it can affect cardiac muscle, and therefore can even lead to cardiac arrest. The first thing is that it can be quite challenging because the patients that tend to get hyperkalemia might have a multitude of other medical problems and be on multiple drugs. They might have recurrent hypokalemia if the underlying cause isn't managed, for example, and then you're kind of stuck with figuring out how to get them better. But what I would say is about hypokalemia, it's one of those things where, as an F1, thankfully, there's clear guidelines on your intranet, your trust intranet, which is your #1 source of what to use whenever you're encountering any issue as an F1 or even higher. So you should know exactly what you need to do in that situation. But regardless, we'll be going through kind of the general guidelines through this talk. So we'll go back to question 1, see how everyone did. So 5.5 was the correct answer, and most of you did get that. So we'll just have a look at the leaderboard. So we've got OA and then a sunflower and someone who's anonymous after that. And then we'll see how we get on. So we'll go on to question 2. And this is asking, what is pseudo-hyperkalemia? So I've got a multitude of options there. If you think about the term pseudo-hyperkalemia, break it down, think about what it might mean. And then you should hopefully be able to suss out which one's the correct answer. But if not, that's fine. We're going to go through everything now. So you need to think about potassium in the sense that it's something you ingest, undergoes various reactions, etc., in the body, and then is excreted. So there's clear situations during that pathway in which you might be able to get a derangement of some sort. So we're going to go through the causes based on that. And of course, during the process of drawing blood, getting it checked in the lab, for example, you can also introduce an error, which is an artifact, which is the final example, broad example of how you can get a hyperkalemia. So I'll go through those in turn, sorry. So first one is increased intake. So maintenance potassium requirements for an adult, 1 millimole per kilogram per day. So if you're prescribing IV fluids and you're giving them way more than they need, then that can be a cause of a hypokalemia. In a similar way, TPN, and even oral potassium, so Sandoz, which we'll talk about later, which is used to treat low levels of potassium. Unfortunately, sometimes people don't stop it and patients just carry on taking them every day and they end up with a hypokalemia. The other source of a hypokalemia can be with patients, for example, that are taking salt substitutes. They might be wanting to reduce their sodium intake. And a lot of these substitutes use potassium chloride rather than sodium chloride. They can, in theory, take too much of that, especially if they've got other risk factors for hypokalemia, that can be a cause. And then the final example here I've given is transfusions. Patients who have rapid and large volume transfusions are also at risk of hypokalemia. Next category is decreased excretion of potassium. So potassium is mostly excreted by the kidneys. So obviously anything that causes renal failure of some sort, for example, an AKI or CKD, that reduces the glomerular filtration rate and you'll get less potassium excretion. Similarly, it's the renin-angiotensin-aldosterone system that regulates how much potassium is in the body. So anything such as Addison's, where you have hypoaldosteronism, or you have potassium-sparing diuretics, aldosterone antagonists like spironolactone, ACE inhibitors, and ARBs, they will all act on that pathway and can cause a high potassium level. Other things you might not necessarily think about straight away are things like Nsaids. They can also cause a hypokalemia through their action on the sodium-potassium pump. And in addition, trimethoprim, which used to be a very in vogue antibiotic for UTIs, it's still used, but that can also act as amiloride does, which is a case-sparing diuretic, and it can cause a hypokalemia. So you need to watch out for those drugs on the drug chart with these kind of patients. The other cause of a high potassium, extracellular potassium level is that you're getting release from intracellular stores. So cells, for example, that undergo tissue injury, like in burns or hemolysis, tumor-lysis after chemotherapy, for example, when they lyse, they obviously release their intracellular potassium. Low insulin levels, so insulin usually causes potassium uptake. So if you've got low relative insulin levels, like in DKA, you can also get a high potassium. Acidosis, hydrogen ions on potassium are exchanged. So as your cells try to take in more hydrogen ions, they have to get rid of their potassium extracellularly. And that's another cause. And then you have drugs like beta blockers and digoxin, which again work on the sodium potassium pump, and succinylcholine, which can also at the NMJ cause high potassium levels. So sorry, it's a long list of things, but I just thought it'd be useful for you to maybe later come back and look at these. And then you've got kind of not an exhaustive list, but this covers kind of the main culprits. Final thing is an artifact. So you can get this when there is any situation in which your in vitro potassium levels, as recorded by the lab, are not a true representation of the in vivo levels. So you can have a hemolyzed sample. You can have an old sample where you get potassium leak. You can have contamination. So the full blood count bottles contains EDTA. And please, please, please never try and send a sample to check for your electrolytes if you have mistakenly put it into an FBC bottle and decide to decant it into the UNE's bottle. You will get the wrong result. And similarly, it's going to make you very worried for no reason. So just, discard that bottle and just do it properly with the UNE bottle. In this example, it's the yellow top. And other things, so leukocytosis, thrombocytosis in the blood, they can also cause high potassium levels. And then, technical things when you're taking the blood, if they're having a drip through their arm with potassium in the fluids, you're obviously going to get a high reading if you take blood from that arm. And finally, really obvious, but does sometimes happen if you're taking bloods from the wrong patient. You can usually tell because it will be quite different from their previous bloods, but just double check that you've got the right patient you're taking blood off. So we'll go back to the Kahoot. We have got most people have answered the correct answer. So it's high potassium due to an artifact. And we'll just have a look at our board. Anonymous has gone up to the top, and the sunflower, I don't know who that is, but you're doing quite well, still at number 2, and a couple of other people as well. So we'll go on to question 3. So we know about the background of hyperkalemia, how it can be caused, but what is the first priority in its management? So I don't want you to just think about how to treat hyperkalemia, but what is the thing that we're most worried about and how do you treat that? So I'll kind of be alluding to this next when we discuss the symptoms. So symptoms, so you get a potassium reading from the lab. They either call you or you're asked to chase bloods in the evening by the day team and you see, oh God, they've got a really high potassium level. You need to go see that patient, check if they have any symptoms of that high potassium level. The thing is that most of these patients will be asymptomatic, but that won't necessarily reflect how bad the potassium level is. Other things that they can report are cardiac symptoms, for example, chest pain, palpitations, and again, like we said, it can lead to arrhythmias and arrest. Other muscles might also be affected. They might have fatigue, weakness, things, kind of vague symptoms, but it's important that you ask about them because that will help in deciding what management pathway you go down. Investigation. So, as we said, there's a lot of causes of a high potassium level, so you need to investigate. The first thing I'll mention is that if you think you have got an artifactual reading of this potassium, it just doesn't fit in with the previous blood test results, or it's just completely unexpected for this patient. If they haven't got any cardiac sequelae, so ECG changes or symptoms, then have a low threshold to repeat it. It's very quick to do a VBG, a venous blood gas. You just straight away run it and check the potassium on that. Otherwise, you can get on with treating, and obviously you can do these extra investigations to try and figure out what the cause is. So capillary blood glucose, ketone levels for DKA, FBC count for the platelet level, leukocyte level, renal function, obvious, liver function. Failure can also cause a hypokalemia because cells take in less potassium, and CK creatine kinase to check for rhabdomyolysis. And then again, digoxin is a cause of hypokalemia, so you want to check that if they're on it. And then serum cortisol or aldosterone if it's relevant. So we're going to go on to the ECG changes that you might see. So anyone with a hypokalemia, you need to do an ECG. The typical thing that you probably learn at uni or school or whatever is you see tall tented T waves. So that is most often and easiest to see on the precordial leads. So that's V1 through V6. But you need to remember that tall T waves are also a normal variant. So it might just be that that's the normal look of their ECG. So you want to make sure you compare it to a previous ECG, so you're not kind of more worried than you should be. You also get other changes as you go across the ECG trace, and the list I've put up here is a reference for you to kind of come back to, so you know what you're looking for. So, but in general, you get flattening of the P wave, you get PR prolongation, QRS as well. You can eventually get a sine wave pattern, and it can progress to asystole. So I've got pictures up here, if you can see that, of ECG changes that you can see. So I've got normal example at the top, and then with an increasing severity of hyperkalemia, you progress from a peak T wave to widened PR and QRS intervals, and finally you can get a sinusoidal wave and the rest asystole eventually, but hopefully you will catch everything much earlier than that. This ECG trace is just to show the digoxin effect. So if patients are taking digoxin, then you sometimes can get this reverse tick sign, which you can see up on the screen now. It's not a sign of toxicity. It's just a finding that you can see on the ECG if someone is on digoxin. So it's just useful to know that that's what you might be able to see. So I'll go on to management. Let's check. Yeah, so management, as I said, you'll probably on your intranet have a table or kind of a flow chart that you need to follow. As I said, this is general, but if a patient's got severe hypokalemia, or they've got evidence of myocardial instability, which is on the ECG changes, sometimes even some guidelines say if they've got symptoms, then you need to follow this pathway. Now, the main thing is that you're initially temporarily trying to reduce the potassium level. And then obviously definitive management is treating the cause, but the emergency is focusing on that. First and foremost, you want to be stabilizing the cardiac membrane, because that's what you're worried about the most, obviously. So you need to make sure they've had their ECG, like we said, but also that they remain on cardiac monitoring if they fall under this category of treatment. The way you stabilize the membrane is giving a calcium salt. So 10 mils of 10% calcium chloride IV, or in some trusts it might be calcium gluconate, and the dose might range for that 10 mils to 30 mils. So definitely just check your guidelines. So you've stabilized the membrane now, but that calcium salt doesn't actually reduce your potassium. So you need to try and reduce it in the fastest way possible. And the way to do that is on our next step, which is driving it into cells. Like we said, insulin can cause potassium uptake. So that's what you give to patients. Typical prescription would be 10 units of Act Rapid, and that will be in 100 mils of 20% of glucose. Another way to drive potassium into cells is using a beta agonist. So salbutamol nebulizers are typically used. Guidelines say 10 to 20 milligrams. I've never personally given more than 5. you know, at a time, and then you can do back to back if needed. And then if these measures aren't working, there is an opportunity to give repeat doses based on your guidelines after a certain amount of time. But if, you know, this patient's hyperkalemia is just absolutely not amenable to pharmacological management, you need to find a better way of removing that potassium, and this is where a higher level of care is required. So you need to think about hemofiltration and dialysis. In any case, during this, if you're on this side of the pathway, you need to let your senior know, so MedReg, and particularly, you know, if you reach this stage where you need ITU level care, they can facilitate those kind of discussions. Finally, remember that you always need to recheck the potassium, typically after 1 to 2 hours, and also again at 4 to 6 hours. So you make sure you haven't got a rebound. But that's important. You might be trying all of this and think you've sorted it out when you haven't. So definitely remember to recheck the potassium. So regardless of the severity, so if you've got a patient with mild to moderate hypokalemia without any cardiac signs or symptoms, but also in the severe cases, you need to think about certain things to definitively treat the high potassium level. So try and identify the cause and treat it. If it's a drug that they're on that's really obvious and it's safe to remove it or even change it, you know, do so. If you are wanting to remove additional potassium, you can use diuretics, or calcium resonium is an example of a GI tract potassium binder, but that does have some GI toxic effects. So again, if you're doing anything like this, speak to a senior. Don't do it kind of independently. And also that takes a few days to kick in, the calcium resonium. So it's not the initial kind of treatment. Another way you can help is by reducing their potassium intake. So let the nurses know, but also document, put down, you know, patient to follow a low potassium diet, and that will restrict how much foods like potatoes, bananas, nuts, etc. they can have. Finally, you can attempt to shift potassium intracellularly using things like bicarbonate, but again, that's something you should discuss with a senior. So just a quick summary. Diagnosis, you should make sure it's not spuriously raised potassium, obviously. But once you're sure it's correct, then be aware of what level, what severity the hypokalemia is, so mild, moderate, or severe. Then you need to investigate with certain bloods to try and identify the cause, for example, repeat if you need to, and also definitely do an ECG. When it comes to treatment, like we said, if it's severe, so more than 6.5, or there's ECG changes, or they've got symptoms, start with the calcium salt to stabilize the heart, then insulin dextrose and salbutamol if you're trying to get potassium to enter cells. And you need to think about whether you need ITU level care if these measures aren't successful. Regardless, in all patients, you need to try and treat the cause, think about their diet, and consider potassium binders. Definitely always you need to remember to recheck the potassium levels. So I don't know, Annabelle, if we have any questions at the minute, just in the, we could maybe answer them before we go on to hypokalemia, but I'll just go back on the Kahoot in the meantime. So we have got, yep, so as I said, calcium salt is the priority in managing hypokalemia. So you need to make sure that you stabilize the heart. So we've got, oh, the sunflower's gone up to first place. Anonymous still doing well. Laura's come up, and a couple of others. So we'll, I don't know, Annabelle, do we have any questions?
Yeah, we do. We have 2 questions come in.
Cool.
So the first one is, you've mentioned calcium chloride, and this user asks, you've mentioned calcium chloride, why not calcium gluconate? So I think maybe if we could just go through what the difference is and maybe why they're different in different hospitals?
Yeah, so I'm not going to claim to know that much about it, but in different hospitals, it's based on your guidelines, what is typically used. So as I said, if your hospital uses calcium gluconate, use that. If not, then use calcium chloride. Calcium chloride actually has 3 times the amount of calcium that calcium gluconate has. And that's why I kind of alluded to it. So they're 10% solutions. You'd use 10 mils of calcium chloride. And in some places, they still use 10% of calcium gluconate. Some places, because of that difference in calcium content, they might suggest 30 mils. So it just depends on what particularly is on your trust guidelines, what is available in your hospital. There are some kind of other differences with them. I think I'm not going to make any claims, but that it's just basically what your hospital has. That's what you end up having to use. But I don't know if Akash has anything else to add to that I've missed out on.
No, that's absolutely perfect. Just as you said, calcium chloride has got 3 times the amount of calcium. You can literally use either interchangeably. I tend to prefer calcium gluconate as an endocrine reg, just because it's less irritating to veins. But otherwise, Fatima, you were 100% correct with exactly what you said.
Cool.
Great question, by the way.
Yeah, it's a good question.
Yeah, lovely. So, and the next question is, does the 10 units of Act Rapid come ready-made in the syringe with the glucose, or do you have to mix it?
Okay, so interesting question. I'm gonna admit that the thing is, you as the doctor are not going to make up the preparation. You just prescribe it. If I'm honest, I've never actually stayed on until kind of to watch the nursing staff when they administer it. So I don't actually know. I can only imagine that it doesn't come together. They kind of dilute it. And then in some places you might have different volumes and percentages of the glucose solution that you use. So again, you just need to worry about prescribing it. Someone will sort it out. But Akash, again, I don't know if you want to jump in.
Yeah, so I can totally chip in there. They come as different solutions in almost every place. They have to specifically make it up, where they add in the insulin usually into the infusion. You can give it separately and have both run concurrently. But we often do say to give it inside the infusion, just to avoid the risk that only the insulin goes through and that the dextrose doesn't go through with it, because otherwise you might end up getting a patient with quite the severe hypoglycemic episode, which often does occur when you do give calcium. Sorry, if you do give insulin dextrose. So yes, in most places they will have to give it separately, and you may vary up the amounts that you give depending on what your trust policy is. So do check that out and just go along with what that says.
Excellent. We've got one more question in this interim section, Fatima.
Yeah.
Someone has asked, if you suspect Addison's, would you take a serum cortisol or schedule them for a morning serum cortisol?
Again, Akash is the expert on this, but as far as I'm aware, and what I do is that's not the first thing that would pop into my head when I'm trying to treat a hypokalemia. I try to treat it with the measures. Like I said, I wouldn't necessarily try and do all these investigations before that. I would do a morning cortisol, but Akash is the pro on this, so he can jump in again.
Yeah, sorry, all of these are endocrine questions, and that's my specialty. That's why I'm helping Fatima out with some of these questions. But just before I go into that, thank you so much to all the nurses who've written on the comments letting us know that you do have to mix it. It's really helpful to have this kind of multidisciplinary approach.
Yeah.
And have all of you guys providing your insight. On to the question about whether I do a cortisol in the middle of the night or whether I'd wait until the morning. If you've got a patient who you're very much suspecting has got adrenal insufficiency, i.e. they are vomiting, they've got postural drop, they've got all the other features, salt craving or whatever else, then I think it's very much worth doing a cortisol in the middle of the night, because ultimately you'd expect when they're vomiting and other things that they would have some sort of a stress response. The best time to do a cortisol is in the morning, because that's when we expect it to be the highest. And so a low cortisol in the middle of the night isn't so helpful. But ultimately, if you've got a patient having what you suspect is an adrenal crisis, what you need to do is get on and give them their treatment, because you can't wait until the morning. So what you'll do is you'll send a cortisol off, just to make sure that, because if it comes back and it's absolutely plumb normal, you're reassured that actually perhaps that treatment wasn't necessary. But in the meantime, just to make sure they're safe, you'll start the treatment, you'll give them some fluids, and you'll make sure that you've sent off that cortisol, just so that you know at the end of the day whether you went down the right way or not. Once again,
Thank you
great
so
question.
much, Akash. Thank you.
Brilliant. Yeah,
Thanks, Annabelle.
we've got one more speedy question.
Okay.
When you do the act rapid and the glucose, is it something you write up in the stat part of the drug chart, the fluids part, or the insulin part?
So not in the insulin part. Probably the best place to write it is sometimes the nursing staff want you to put it on the back. Sometimes they want you to put it on the stat. To be honest, I just follow what they tell me. On the stat side, obviously they can, appreciate that it's more urgent. So as long as you make sure that it's prescribed somewhere, the nurses are happy with the prescription and they give it, which is again something I should have made sure to mention. Once you prescribe things, you need to make sure that it's given. Sometimes, other emergencies happen on the ward and people kind of forget about it. So you definitely need to keep checking in that everything's been given. But when it comes to the prescription, personally, I just kind of write it down, let the nurses know. If they say, no, actually, can you do it on this side? I'll just do it. It's not something I think about too much. I don't know, Annabelle, what is your experience?
I would agree with you. I think that mainly I would probably go for the stat side, but sometimes nurses prefer it on the back, on the fluid side. And I don't have a strong preference either way. So if the nurse in charge has a preference, I'll go with what he or she wants.
Yeah,
I think that's very sensible. Lovely. So that's all the questions for this bit.
Cool.
And then I'll come back with some more at the end.
Cool. Thank you. Thanks so much, Annabelle. And thanks, guys, for all the questions. So we're gonna go on to hypokalemia, and hopefully this will be a lot quicker because a lot of it is just the opposite of what we just talked about. But I'll try and highlight the key things that you need to think about that are different. So we can go on to that. Again, same kind of structure, give you classification, importance. We'll go through the causes, symptoms, and then what you need to do, investigations and management. So potassium levels in hypokalemia, you are expecting a level less than 3.5 millimoles per liter. And again, mild, moderate to severe. So 3 to 3.4 is mild, moderate 2.5 to 2.9, and then severe is less than 2.5. Again, it is something quite common, and if you've got hyperkalemic patients and you overtreat them, you might end up on this side. And additionally, potassium derangement often comes in with kind of other electrolyte derangements. So you may see this quite often in conjunction with other abnormalities. Again, it's life-threatening. Most people just consider kind of hyperkalemia as the main thing that can cause arrest, but it's important to know that hypokalemia can also do that. And again, it can be challenging. As I said, you can end up yo-yoing between the two, hyper and hypo, and sometimes, if there's an organic cause, it can become very tricky if you're trying to increase someone's potassium levels to normal. So we'll go on to question 4 just before that. So it's a bit cheeky of me to ask this because we haven't gone through it yet, but which of the following is not a cause of hypokalemia? So you can think of this as which is a cause of hyperkalemia, and seeing as we just went through that, you might be able to figure it out. So just give you a bit of time to answer that before we move on. So again, we've split up the causes according to the same kind of 4 broad groups. An artifact, though, with hypokalemia is not as common. The only times really I can think of that can happen is if you've got the wrong patient or you're doing it from a drip arm where there's no potassium content there. So we're not going to go into that too much, but the other three we'll go through in detail now. So inadequate intake, again, if you're not giving them enough through IV or TPN, or they just might have a poor oral intake. So this is something you need to think about in psychiatric patients. If they've got eating disorders, they can often present with hypokalemia. So sometimes we don't really pay too much attention to a patient's psychiatric history on medical wards, but it's something that you might need to take into account when they've got electrolyte abnormalities. Next one is you might just have increased excretion levels, and that might be through the two main routes. So as I said, GI tract, classic things with, for example, gastroenteritis, vomiting, diarrhea. If patients are taking too many laxatives as well, can cause the same thing. They might have malabsorption or a high output stoma. So that can be fairly common in stoma patients on surgical wards, for example. Renal causes, so you can have a variety of genetic syndromes. Again, cons on Cushing's, you know, in contrast to the Addisons causing the hyperkalemia. Steroids as well, things like prednisolone. And renal tubular acidosis. There's type 4 actually can cause a hyperkalemia, but these types I've mentioned, 1 to 3, especially 2, can cause low potassium level. Again, non-potassium sparing diuretics can cause low potassium levels. And then one key thing you need to think about is magnesium levels as well. So if you have a low magnesium level, it can contribute to that low potassium. And in fact, if you're trying to treat a hypokalemia where you've also got low magnesium, you need to make sure you treat the magnesium first, because that will help ensure that you succeed in trying to treat the hypokalemia. And then again, you know, the opposite of last section of hyperkalemia, you can also get an extracellular to an intracellular shift of potassium. So alkalosis, insulin, and again, as we discussed, adrenaline or beta-2 agonists. I'm just going to go back to question 4. So most of you got that right, low insulin. Low magnesium was also popular, but that's wrong because it can cause hypokalemia. So we'll check there. So, oh, sunflowers stayed on top, but we've got new people on the top 5 leaderboard. And then we'll move on to question 5. So, which of the following is true regarding the relationship between potassium and digoxin? I'm just going to let you think about that. Sorry, I'm just having low, just need to plug in my computer. Sorry about that, just low charge. Right, so if you think about how digoxin works on the NAK pump, you should be able to answer this. But again, we'll get to that anyway. So moving on to symptoms, again, it can be asymptomatic, like hypokalemia, but you still can get some cardiac symptoms and muscular symptoms, and they really are similar to hypokalemia. So you definitely need that reading to make a diagnosis of potassium, high or low, because they can be quite similar. You can get palpitations, you can get arrhythmias, you can get flaccid paralysis, weakness, etc. One other point I've mentioned here is that a low potassium level can exacerbate digoxin toxicity. And that's something to think about. If someone is on digoxin and they have a low potassium, that can make them exhibit symptoms of digoxin toxicity, which again are fairly similar to the symptoms you would get with hypokalemia anyway. Investigations, right? So bloods, similar to last time, you know, you can look for all sorts of causes, but the key one I'm trying to highlight here is make sure you check the magnesium as well. Anytime you've got a low potassium reading for a patient, you need to also check the magnesium, and you can just add it on at your lab. You don't technically need to take a repeat blood test. If there's no other reason to, you can usually just ask your lab through various, there's protocol. Maybe you have to print out a request or just do it on the system, and you just ask them to add it on. And then obviously, like I said, ECG, because you're looking for any changes. And the changes here are different to the ones with hyperkalemia. Instead of a tall tented T wave, you might get a flattened one. You might also get U waves, which come up on the trace after the T waves. You can have ST depression, and again, you can have longer intervals like the PR and the QT. So this is just a quick example here, where you can see normal at the bottom and an example of hypokalemia at the top. So you have a depressed ST segment. You can also have a flattening of the T wave and a U wave as well. Obviously, you need to take it into context. If you have a depressed ST segment, obviously there are other causes of that. These are some of the findings on an ECG trace with hypokalemia. So just go back to our question about potassium and digoxin. So that is correct. Low potassium exacerbates digoxin toxicity, which we just mentioned. And most of you have got that right. If you think about it, digoxin, it works by inhibiting the sodium-potassium pump, which causes potassium influx. And if you've got low potassium extracellularly, then you're reducing that concentration gradient even further. So they kind of work in harmony to try and inhibit that pump. So I'm going to enable the final question after this. Oh, GMC's come up as well. Okay. So it's quite tight. There's still all to play for on the last question. So last one, which of these is the most suitable prescription for ward-based IV potassium replacement via a cannula? So think about what I've put there. I've said it's ward-based, and I'm saying it's via a cannula, so peripheral. So you need to think about concentration, rate, and just general suitability of the prescription. So again, we're going to be going through that. So if you're not sure, that's okay. It's still to come. Management. So in a similar way to hypokalemia, you've got two distinct pathways. If it's moderate to severe hypokalemia, or there's any evidence of myocardial instability, you need to get that potassium up quicker than if it was just a mild form. So in that case, you use IV potassium. The thing to remember about potassium is that you can't kind of decide a certain amount you want to add or mix in with another bag, for example. They come in pre-prepared preparations, and it's usually in forms of 10, 20 or 40 millimoles per liter of normal saline or dextrose. 40 millimoles per liter is typically the maximum concentration you can give peripherally. And you definitely don't want to be thinking about physiological fluids like Hartmann's or Plasma-Lyte, because they only contain 5 millimoles per liter. So that's not going to be useful in this situation. Standard rate at which you give these fluids is important as well. Usually you give it at about 10 millimoles per hour max. At 20 millimoles per hour, you definitely need to think about having continuous kind of monitoring. And sorry, yeah. And the last thing I've put on there is definitely, like I said, if magnesium is low, then you want to treat that first. In your hypokalemia intranet guidelines, it will mention that as well, so you don't forget. Last thing is that if a patient doesn't fall within this kind of bracket, so they've only got mildly low potassium, you can still give IV if they're not tolerating the oral treatment. So that's, to your kind of discretion. If, they're vomiting or they're just not doing well with the oral tablets, by all means give IV potassium. Regardless, if you're on this kind of side of the pathway, or you need a rate higher than 10 millimoles per hour, again, discuss with your seniors. You've always got support as an F1. You're not kind of left to your own devices. if you're worried about something or something you've never done before or anything, seniors are always happy to just hear you say, oh, just checking with you, this is what I've done, is that okay? And I'm sure Akash will agree with that. So if you've only got a mild hypokalemia and you haven't got myocardial instability, you can very well just treat them with oral potassium. So Sandoz is the classic tablet that we use in the UK, and typically prescriptions, which either it can be on your guideline or you can choose based on exactly how low the potassium is. It can be from 1 tablet once a day to 2 tablets 3 times a day. I think there are some places where they give 2 tablets 4 times a day, but I think once you've reached that stage, you just want to, you're going to think about giving IV rather than oral. One key thing you need to remember is that if you ever prescribe this, please put a stop or a review date at 2 to 3 days, because it happens on the ward, unfortunately often, where you know, someone might prescribe them Sandoz and they'll think, oh, you know, in 2 days I'll remember to cross it off, but no one ever does, and they end up with a hyperkalemia. So definitely put that stop or review. And then again, for all patients, as with hyperkalemia, you're going to try and treat it definitively, so it's not a recurrent issue. You're going to try and treat the underlying cause. So quick summary there. Again, diagnosis is split into mild, moderate, severe. Investigations you need to do: bloods, ECG, and remember the magnesium level we talked about. If they've got moderate to severe, or they've got ECG changes, symptoms as well, you want to give IV replacement. And again, like we mentioned, the magnesium. And regardless if you're on this side or if you want a fast rate, you need to discuss with your senior. And again, if they've only just got a mild level of hypokalemia, you can give them oral tablets and they should improve with that. Definitely put the stop date, and with all patients, treat the cause. So I've just put up a few links up here. So on the mindthebleep.com website, we've got articles for these, hyper and hypokalemia. It'll, I think, probably be added on the chat as well. And then I've just linked to lifeinthefastlane.com, which, you know, I don't have any affiliation with. It's just it's a useful place for ECG, looking at ECGs, and I definitely still use it when I'm on the wards. Finally, the best source of information for what to do in any of this is your trust intranet. They're very good at telling you exactly what you need to do step by step. So that is the definitive thing you need to follow once you start working. And yeah, thanks guys for listening. If it wouldn't be too much trouble for you, we'd really appreciate some feedback. We'll put the link on the description, sorry, the chat. I've also got it up here, and there's a QR code. You will get a certificate if you fill it in, which is good for your portfolio. It shows you've been learning. But also, again, it will help us to improve and make these better for you each week. You guys mentioned you wanted polls. We tried to include that. If you're still for it, you know, you can say that on the feedback. If you don't like it, you can say that as well. Anything else, it will be really useful for us to know, because at the end of the day, we want this to be helpful for you. So if there's ways we can do that, please let us know. Obviously, this is something we also need for our portfolio, so we would highly appreciate if you could please give us feedback. We'll take some questions. I'll just go quickly back to the Kahoot just to check. So yeah, sorry about giving you this question without explaining it first. 40 millimoles potassium in a litre of 5% dextrose over 8 hours is the correct answer. It's actually better to give it in normal saline, but this is fine as well. It's a suitable prescription. The first answer, 60 millimoles per litre. That's too high concentration, like we mentioned, to be giving peripherally. 40 millimoles in 2 hours, that's too quick to be just kind of giving on the ward. That's 20 millimoles per hour. And then C, I kind of tricked you a little bit. I put 9% NaCl instead of 0.9%, so obviously that's incorrect. And then, yeah, that's it. So just check our leaderboard. GMC is third. That's good. And here's this. Oh, Sunflower's falling second. That's still good though. And someone's coming at the top. Who is that? JC, well done. Nicely done. It was hard questions, I can't lie, but supposedly it helps you learn when you get questions wrong. So well done to everyone who took part. And again, yeah, thank you. If we have any questions, otherwise we can do the feedback. Unless we have anything else to do. Is Annabelle around?
Yeah, so while people just do the feedback, there's a couple of questions. So the first question is referring to community patients. So someone has asked, if a patient is in the community and doesn't want hospital admission, is there a way that you could treat them without them getting hospital admission? What's the best practice for treating them?
Well, that's an interesting one.
Bit of a tricky one.
Yeah, it's a bit. I'd say, so the thing is, high potassium or low potassium levels, for example, it depends how severe it is. So if it's, and often you do have patients, Annabelle, as I'm sure you'll agree, sometimes on the water they might have slightly low potassium, and then you can still discharge them from hospital if it's it's safe to do so. But again, you discuss that with your seniors. It's not something you would personally decide, and bring them back, for example, to ambulatory care, which is usually units that hospital have in which kind of some forms of hospital treatment like IV antibiotics, etc., are given to patients where you're trying to kind of minimize admissions. So they might need IV antibiotics, but they don't necessarily need to be watched all the time, for example. So you just make them come in whenever they need a dose and you give it to them. And then similarly, if you've got a patient who is otherwise well fit for discharge and you only need kind of correcting of their potassium or just checking it and it's just mild, you can send them home and tell them, come back in a few days, we'll check the level after we give you, for example, oral replacement in ambulatory care, just to check. So I think it depends, and it's hard to kind of give a general answer, but where it's safe to do so, you can treat them in the community.
Yeah, I think that's very reasonable. And I think, you raise a good point about that you've always got senior support, or at least the higher up you go, you've also got your peers as well. And something like a discharging decision or an admitting decision will often be a team effort as well. And then
sorry, I was just going to say, as an F1, you are not going to be deciding who gets admitted or who stays in the community or anything like that. That's definitely above your pay grade, so that's not something you would be expected to do. Sorry, Annabelle.
No, I'm sure a big sigh of relief as people are watching. And then we got a nice question here saying, what does F4 mean?
Okay, fine. It's a kind of made up term, I guess. Well, it's not, it's basically when you're not on a training pathway. So you do your F1 and F2, which is recognized training positions, and at the end of that you get your FPCC, I think it's called, and then you're technically SHO level at that point. People can go straight into training, so like medical IMT, core surgical training, or I don't know, other things like ophthalmology or ACCS, whatever it is. Or you can just decide not to be on a training pathway, so you can carry on working in a trust grade position on a contract, or you can carry on working just as a locum. It's up to you. So some people like that there's that freedom and flexibility. Some people want to do it for trying to figure out what training pathway they want to do, or they just want to build up their portfolio because it gives you a bit of time to do that. So that's what an F4 is. It's not any kind of training position, but you're still kind of working at an SHO level.
Brilliant. And there's just a little disclaimer from the previous question about community. This participant has said, I feel more connected in communication with community and acute. Sorry for the difficult question.
No, that's fine.
We absolutely welcome all questions.
Definitely.
But if there are any more questions, please just let us know. Our email address is info@mindthebleep.com. It'll come straight to me, so I'm more than happy to answer any more questions that anyone's got. So please keep them coming. Do also look out for our next session. So our next session is on hypoxic emergencies. As you can imagine, it's incredibly popular because the amount of patients that we all see, and Fatima, you know this as much as I do, literally every day we're called to a patient who's desaturating. And so it is an incredibly important topic wherever you are for you to attend this talk. So please do check it out, sign up, and let all your friends and family know to join in as well. Moving on, so the first thing we need to say is a massive thank you to Fatima and Annabelle for putting on such a wonderful session today. You can see from the feedback already that people absolutely love this session. They love the Kahoot. So you can see how amazing a job Fatima has done. So massive round of applause for Fatima.
Thanks, everyone.
Brilliant.
And also for Annabelle. Oh my gosh, Annabelle's going to be so upset if I haven't given her a massive applause.
Yeah, no, thank you, Annabelle, as well.
No, brilliant, Fatima. Fantastic.
Thanks, Akash, for jumping in at all the right moments.
Oh, don't worry. I'm just here in the background. Next, I think we have a wonderful talk from Daniel Tyler. So we'll just let him take over the screen, and he's going to tell us all about the BMA and how incredibly helpful they are. So you really want to turn up for this session because Daniel Tyler always gives a great session on everything.
If I can unmute. Okay, I think you should be able to hear me now. Wow, what a build up. I hope it's that good. So just from me, I'll be very quick. I hope you guys sort of stay on to hear my bit. Hopefully Akash would have shared in the chat sort of some links that I sent over to those guys. If you wanted to sign up here from the BMA using the QR code on the screen or those links in the chat, it doesn't mean you're signing up to membership. It's just a sort of a way of us giving you a free support pack to you, regardless of whether you're a member or not. So with that, you get a sort of an F1 employment guide, which is useful looking obviously ahead to July. We negotiated the contract, so we know what's going to be in it. So sort of that guide sort of helps break the contract down. You also get a student support pack, so it's featuring some revision tips and tricks, ethics toolkit, if this is still sort of relevant to you, the revision stuff. So there's something for you for the remainder of your studies, and obviously the F1 guide, which is pretty good. Doesn't matter again if you're a member or not. It's just some free guides that we'd like you all to have when it comes to your F1 and obviously to help you now while you're in medical school. So that QR code will be in the top corner throughout the presentation as well. So if you haven't done it, you can do it while I'm talking, or also the links being shared. So yeah, so I'm Dan. I'm just going to talk about membership, BMA of the BMA. I'm sure you're all members, or you've been a member at some point, or you've heard us this year already. So maybe you've come into your school and done contract talk. So yeah, just a little bit more of a refresher of what you get, and hoping you might find out something new as well. So we're the leading trade union and professional association for doctors. We act as the voice of the profession, representing you individually, locally, so within your trust you'll be going into, and nationally on all the trusts, on all the issues that affect you. So while it's your job to look after patients, it's our job to look after you. Like I mentioned, we do things like we negotiate the junior doctor contract. So we're always sort of talking to the trust, and if there's any issues for the doctors, it's us that has to sort of sort them out on your behalf. So we're not an indemnity company, so we do get this confusion sometimes. So we're not like MD or MPS. We don't deal with patient complaints. We're here solely to look after you, your working conditions. So again, things like pay, contracts, your well-being, and also your professional development. So going into F1, we understand the sort of things you might encounter, some issues you might face, but hopefully not. So this can be anything from again, your working hours or sort of relationships with senior staff, or sort of responsibilities that you might not feel comfortable with. So just keep us in mind. We can take some of the pressure off if you're facing anything you feel you need support with. We've seen most things before, and there's not much we can't help with. We've got, like I said, relationships with every trust in the UK, and it's our job to make sure they look after you and they're being fair to you. So you may have heard of our contract checking service, which can save you time and quite a bit of money. So it's probably the key tool of ours that you'll need this year when you're going into F1. So we'll go and we'll check your contract within 5 working days, comparing it to the national model. And if there's any discrepancies, we can help get them sorted. Not to be doomsday about everything, but some trusts do sometimes slip some extra things into your contract or change the wording here and there. I'm not saying they always mean it, but we just want to make sure your contract is what we negotiated, what it should be. You're getting everything you should be getting. 20% of the contracts we checked last year were incorrect, so it's 1 in 5. Bit depressing that it's that high, so it's too high for us, and we just want to check as many of you as possible. So it'd be great if you're members. Also, you can check your rotas compliant by using our rota checker. So with that one, you can enter in your rota, and it will flag up to us using our sort of online tool. It'll flag up to us if it's wrong. But again, your rota should be pretty standard, so that shouldn't really be an issue. As I'm guessing most of you guys are final year students, you're actually eligible for the full BMJ, so the doctor version of the BMJ magazine. So this is delivered every Friday. If you're a member and you're not getting it, just get in touch, send us an email or phone us to upgrade. You don't have to pay any extra money. It's just an opt-in thing. So yeah, if you alternatively to that, if you don't want the paper version and you're getting it, again, phone up or send us an email, because you can access all copies of the BMJ on the BMJ app anyway. So as part of membership, you also get access to our clinical and non-clinical learning stuff. So you have full access to BMJ Learning, which has over 1,000 clinical and non-clinical modules. There are courses and modules on there which are good for sort of completing your e-portfolio when you begin F1. It's all very interactive and kept up to date with practice changing developments. There's lots of audio and video stuff on there as well, so it's a bit more of a simulated environment, not too boring. So for each module we do, you can print off a certificate as proof of learning as well. BMA library is obviously closed at the moment, still due to COVID, but you've got access to thousands of our online books, which you can get straight away through the website on your phone or laptop. So we've also got a series of webinars which are free for members, and they're held live throughout the year on various topics, and they're also available to view on demand if you can't watch them live. Maybe early for this, but if you're thinking about your specialty options already, you can use our Specialty Explorer tool, which helps you get a bit of a picture of what suits you best. So with this one, it's an online psychometric test which takes about 20 minutes, and it'll ask all sorts of work balance questions, and then it'll give you a pretty detailed report listing the specialties according to the answers you've given. Very, very easy to use. It covers all specialties, and the reports are always quite thorough with lots of graphs and diagrams explaining why you should choose this or that. If at any time you feel you need to speak to someone about your well-being, we've got services that are open 24/7 to all students and doctors. You'll have the choice of either speaking to a counsellor or a peer support doctor. So it is a telephone-based service, but we do offer video calls as well if you prefer that. And we'll also make sure you speak to the same counsellor or doctor again if it's more than a singular calls and service. These services are completely confidential of your school, of your trust. And then they're also free of charge and open to everyone. So that's regardless of whether you're in membership or not. So again, anyone's free to use it day or night. So just to round it off for me, if you're not currently a member, there's a bit of an offer today. If you use the link that's been posted in the chat or the QR code on the screen, you'll get a £10 Amazon voucher for joining. So membership's £3.66 a month. So yeah, in a way, the voucher covers for 3 months. If you're starting in July, you'll still pay that £3.66 a month, that student rate. So you'd still join as a student. You still pay that through to October, and then it goes up to £7.80 a month after tax relief. So that's not till October. So you remain paying £3.66. Get your contract checked, get everything checked. and that's the rate you pay. You must use the link on the screen or the QR code or the link in the chat to get the voucher. So don't just head to the website. It's quite special to that link. Okay, so yeah, again, if you don't, this is how we started. If you don't feel quite ready to sign up, that's fine. But just taking our sort of our support pack and the employment guide means that we can stay in touch with you and give you some more sort of stuff that might be of use to you via email ahead of the F1. So yeah, that's it from me. I'll round off and stop my sharing the chat. Okay, great. That should be done.
Thank you so much, Daniel, for covering all of that. Personally, I'm a member of the BMA, so I can't recommend them more. Joining them for the first few months is absolutely helpful for getting that contract checked, making sure that if you're running into any issues that you get all of that sorted and all of the extra stuff, because starting F1 is very overwhelming, particularly for the first few months. You don't really know what you're doing, what you're meant to be doing, what is part of your role, what isn't part of your role. And just having that BMA to support you with any kind of pay issues, rotary issues, or any other things that you get, just helpful to just make sure you've got somebody looking after you when you're looking after so many people. Perfect. That's the end of our session today. Once again, make sure you come and attend our hypoxic emergencies and absolutely make sure you fill in the feedback because we really want to improve this, improve every session. And so far, as you can tell, every session is better than the last. So please fill in that feedback so we can use your feedback to make sure that we carry on doing that. Thank you so much for attending and have a lovely night.